When diagnosing hypertension in almost 99% of the cases, we often tell patients that the cause is unknown. It's a mere reflection of genetics and lifestyle choices like excessive salt, processed food, sedentary lifestyle, and the daily grind of stress. Moreover, the medications that we prescribe are typically general, not precisely tailored to a specific disease underlying pathology. However, we're now discovering more of a surprisingly common condition that demands a targeted treatment and even offers the potential for surgical cure. Today we'll be discussing the condition, why should we care about it, how to diagnose and how to treat. Welcome to Cardio Buzz.
What's the latest buzz in cardiology? You found it. Welcome to Cardio Buzz, your essential briefing for cutting-edge research and expert interviews. We cut through the noise so you can stay ahead. Don't miss a beat. Subscribe now.
So today we'll be talking about primary aldosteronism, or PA, a topic that can be a game changer for millions of people living with hypertension worldwide. PA is a condition that often flies under the radar. As a doctor, you might recognize the name, but how many times have you actually seen it on a patient's diagnosis? And for patients, it's likely a complete mystery.
Wow. So let's start by defining that mystery. What exactly is primary aldosterone is?
Aldosterone is secreted by the suprarenal glands and it's typically regulated by renin from the kidneys, and their interactions help to maintain blood pressure and electrolyte balance by promoting sodium and water reabsorption and potassium excretion. Renin is released in response to hypotension or dehydration, prompting the adrenal glands to secrete aldosterone and conserve salt and water. Simply put, primary aldosteronism is an adrenal gland disorder where the suprarenal gland produces too much of the hormone aldosterone, independently of its usual regulator, renin. This excess aldosterone leads to the body holding on too much sodium and water, which then drives up the blood pressure. And it's not just about high blood pressure. Excess aldosterone can directly damage the heart, the kidneys, and the blood vessels, leading to serious complications.
So, it is an endocrinal disorder that elevates the blood pressure, right? But is it different from other causes of hypertension?
Yes, you might be wondering, why should I care about PA when I already have a high blood pressure? Here's the critical part. In primary aldosteronism, there are significantly higher health risks compared to patients with typical primary hypertension. We're talking about more than twice the risk of stroke and kidney disease, triple the risk for atrial fibrillation, and twice the risk for heart failure. And despite these serious complications, fewer than 1% of hypertensive individuals are screened for primary aldosteronism. Means that we are missing out on targeted treatments that could drastically improve the health outcomes and even potentially cure the hypertension.
Then who should be screened for PA?
This is where the new guidelines from the Endocrine Society come in, published recently this year. They have a clear message. All individuals with hypertension should be screened for primary aldosteronism.
All of patients, I guess there are around 1.5 billion hypertensive humans with high blood pressure. Should we screen all of those?
Yes, you heard that right. All individuals with hypertension. Primary aldosteronism is the hidden epidemic of hypertension. It is surprisingly common, yet often missed. When looking at the general population with hypertension, primary aldosteronism is estimated to affect 5 to 15% of individuals seen in primary care settings, meaning that 1 out of every 20 or 1 out of every 7 hypertensive patients can have primary aldosteronism. And while it's crucial for everyone with hypertension, screening is especially important in these situations. Hypertension with type 2 diabetes, where PA can be present in up to 19% of cases. Hypertension and unexplained atrial fibrillation, the prevalence is strikingly high at 42%. Resistant hypertension, which is uncontrolled despite 3 different antihypertensives, and primary aldosteronism will be seen in up to 30% of these patients.
So, do we have any clinical clues to guide us to the diagnosis?
We usually start to suspect primary aldosteronism when serum potassium is low, either spontaneous without treatment or even induced by diuretics, because excess aldosterone works on the tubules of the kidney, signaling them to retain sodium and excrete potassium.
So isn't hypokalemia enough to suspect and diagnose this seemingly common condition?
Unfortunately, no. It's a misconception that PA only affects people with low potassium levels or hypokalemia. But here's the scientific truth. Most primary aldosteronism patients actually do not have hypokalemia. Only 9% to 37% will have hypokalemia. So waiting for hypokalemia means missing a vast majority of cases. That's why we should not rely alone on potassium levels for screening.
So how do we screen for it?
The recommended screening method is simple, a blood test that measures aldosterone and renin. These measurements should be ideally taken in the morning while the patient is seated. It's important to avoid dietary sodium restriction in the few days leading up to the test, as this can affect the results. We also check the serum potassium levels, not as a screening tool itself, but because very low potassium can lead to falsely low aldosterone reading, impacting the accuracy of the test.
So once tests are done, how are the results interpreted?
A positive test result means that either renin is low or suppressed, aldosterone is high, or the aldosterone-renin ratio is elevated. Low or suppressed renin is a key indicator of primary aldosteronism, and here the direct renin concentration less than 8.2 microunits per liter. Inappropriately high aldosterone relative to the suppressed renin, here plasma aldosterone concentration more than 10 nanograms per deciliter by immunoassay. This translates to an elevated aldosterone to renin ratio. An aldosterone to plasma renin activity of more than 20 is indicative of primary aldosteronism. And it's good to refer to a local laboratory cut points because the assays can vary, and interpret the results within the context of the overall clinical picture and any medications taken.
Which medications do affect the screening test and which medications don't?
A big hurdle in the past was managing the medications that can interfere with these tests. Previous guidelines recommended stopping all blood pressure medications, which was often impractical and even risky. But good news that the guidelines suggest minimal or even no withdrawal strategies for these interfering medications, depending on the individual's patient safety and feasibility. Some medications raise renin or lower aldosterone, such as spironolactone, diuretics, ACE inhibitors, and ARBs. These can give false negative results. If the initial screening is negative while the patient is on these medications, then it's better to repeat the test on a different day, ideally after correcting any low potassium and withdrawing these medications 4 weeks for MRAs and diuretics, 2 weeks for ACE inhibitors or ARBs. Other medications can lower renin, like beta blockers, clonidine, or non-steroidal anti-inflammatory drugs, and these can lead to false positive screening results. If the screen is positive while on these medications, we might consider repeating the test after withdrawing them for 2 weeks, if it is safe to do so. However, if serum aldosterone is significantly elevated, for example above 15 nanograms per deciliter, then primary aldosteronism is still likely even on these medications.
What if the screening is negative or intermediate, but the clinical suspicion is high?
A negative screening is not always the end of the road. We can consider rescreening in the future if the patient develops unexplained hypertension, resistant hypertension, new or unexplained hypokalemia, or atrial fibrillation without structural disease or hyperthyroidism. If the screening is intermediate, we can go for a simple confirmatory test, which is the aldosterone suppression test.
And how can we try to suppress aldosterone?
In primary aldosteronism, there is a benign adenoma in the suprarenal glands that leads to autonomous, unregulated aldosterone production. And if the serum aldosterone levels are not suppressible, then this supports the diagnosis of primary aldosteronism. We can suppress aldosterone production by giving a high dietary salt, telling the patient to consume 4 to 5 grams of sodium per day for 3 to 4 days, or by giving oral captopril, or by infusing 2 liters of saline and that contains salt. Then we measure plasma or serum aldosterone. If the levels are low, this means that aldosterone production is suppressible and not autonomous, and that makes primary aldosteronism unlikely. But keep in mind that serum potassium must be corrected before the test, and if the patient is taking an MRA and the renin is no longer low, then it's good to stop MRA before the test.
Back to the screening test of renin and aldosterone blood levels. If the screening is positive, what to do next for confirmation, and how do we decide on that?
A positive screening result is the crucial first step. It means that the journey towards targeted, effective treatment can begin. For most individuals with a positive screen, the next step involves deciding on either medical therapy or some surgical intervention to remove the source of excessive aldosterone production. The key diagnostic step is adrenal lateralization. For unilateral PA, here we can provide surgical cure by total unilateral adrenalectomy, and this is primarily offered to individuals who choose the option and who are good surgical candidates. Whereas for bilateral primary aldosteronism, we cannot remove both suprarenals, of course, and here lifelong therapy with mineralocorticoid receptor antagonist is usually offered.
And how do we decide if it is unilateral or bilateral?
We know whether it is unilateral or bilateral by imaging and by measuring the level of hormones from the suprarenal veins on both sides. CT scan can help to find suprarenal tumors, but alone it has limitations in assessing the functional activity of the adrenal glands, and it can lead to misclassification. CT or MRI alone can misdiagnose the cause in up to 37% of cases. Some apparent abnormalities on CT scan, like masses, may not be functional. They are just innocent bystanders. We call them incidentalomas, whereas some small functional microadenomas that produce excess aldosterone may be missed by CT scan.
So CT scan should better be complemented by taking blood samples from both glands, right?
Exactly. We need to complement CT scan with adrenal vein sampling. Adrenal vein sampling is crucial to differentiate unilateral and bilateral forms of primary aldosteronism. But if you reach that stage where a patient is willing to go for a radical cure with a surgical procedure, then you need a team not just of hypertension experts, but you also need skilled interventional radiologists who can sample the tiny suprarenal veins without rupturing them. And also you need a seasoned endocrinologist to interpret the maze of hormones and their ratios. Adrenal vein sampling is a tedious procedure, and the success depends on the experience of the operators. Before the test, serum potassium should be normal and renin should be suppressed. Blood pressure should be well controlled, which may require antihypertensive agents. Diuretics, ACE inhibitors, ARBs, and MRAs generally do not interfere with adrenal vein sampling as long as renin is low. If renin is not suppressed, then we need to change the antihypertensive medications before adrenal vein sampling. And here we rely on medications that have a minimal effect on renin, which includes alpha blockers like prazosin, doxazosin, or long-acting dihydropyridine or non-dihydropyridine calcium antagonist, amlodipine, verapamil, diltiazem. During the test, blood samples are collected from the right adrenal vein, the left adrenal vein, and the inferior vena cava. Then we do some measurements, ratios, and calculations. The first measurement is the selectivity index, where we measure the ratio of cortisol in the suprarenal gland divided by cortisol in the inferior vena cava. This confirms the successful cannulation of the adrenal vein. And then we have lateralization index. And this is a complex formula where we take the ratio aldosterone-cortisol from one side divided by the ratio of aldosterone-cortisol on the other side, or the cortisol-corrected aldosterone ratio from the dominant adrenal vein to the non-dominant adrenal vein. And if the ratio is more than 4, it indicates a lateralizing aldosterone excess. If the ratio is less than 3, then it suggests bilateral aldosterone hypersecretion. A ratio between 3 and 4 is a gray zone, borderline, that requires cautious interpretation, CT scan, and maybe further tests. Sometimes infusion of co-syntropine, which is a steroid stimulating agent, is helpful to maximize the gradient of cortisol from the suprarenal vein to inferior vena cava, which helps to confirm that we took the sample from the adrenal vein. This infusion also helps to maximize aldosterone secretion from the adenoma and reducing the risk of sampling during a quiescent phase of the tumor. If there's concomitant autonomous cortisol overproduction, this can complicate the test further. We also need to measure plasma metanephrine during the adrenal vein sampling to help lateralize both aldosterone and cortisol secretion in such cases.
Oh my God, looks like a really tedious and cumbersome test. Can't we just bypass it and go to treatment or another test?
Yes, it's a complicated and very tedious test, and we can bypass that invasive test in 4 cases. Number 1, if there's no desire for surgery, or if the patient is a poor surgical candidate. Here, medical treatment is enough. Or when we have high probability of unilateral disease. This is typically seen in a patient younger than 35 years with marked primary aldosteronism, marked hypokalemia, significantly elevated plasma aldosterone concentration with suppressed renin, and a unilateral adrenal adenoma more than 1 centimeter on CT scan. We can also bypass that mild primary aldosteronism, who typically have bilateral disease, and go directly to medical treatment with mineralocorticoid receptor antagonists. The fourth situation where we can bypass that test is in familial hyperaldosteronism. Patients from families with germline mutations associated with familial hyperaldosteronism, they typically also have bilateral disease, and adrenalectomy is not indicated.
Okay, so surgery is curative in all cases, right?
Adrenalectomy is an effective treatment for unilateral primary aldosteronism and can be even considered for selected patients with bilateral adrenal disease. Adrenalectomy often cures or significantly improves hypertension, with over 80% of patients seeing improved blood pressure control and 37% achieving normal blood pressure without medication. Patients typically reduce their antihypertensive medications from 3 to 1. Surgery also reduces the severe cardiovascular and renal risks associated with untreated primary aldosteronism and improves the quality of life. Most procedures are minimally invasive, allowing for faster recovery and same-day discharge.
Wow, that seems like a fantastic curative option.
It's a good option, but it's not risk-free. Adrenalectomy for primary aldosteronism carries several risks. The general surgical risks like hematoma, hemorrhage. Patients can also experience electrolyte disturbances, some kidney function changes, often an unmasking of pre-existing glomerular hyperfiltration, and roughly 1/3 of the patients can experience a significant drop in eGFR post-operative. Also, some hormonal changes can be seen post-surgery. Patients with cortisol-secreting adrenal adenomas may develop glucocorticoid insufficiency, requiring replacement therapy in about half of the cases post-operative.
Oh, so you mean that after surgery we may trade aldosterone excess for cortisol deficiency?
Well, it's a complicated relation. Roughly 5 to 25% of patients of primary aldosteronism also have autonomous cortisol secretion from the adenoma. This excess cortisol increases the cardiometabolic risks like diabetes, osteoporosis, and renal dysfunction. It can complicate the results of adrenal vein sampling. That's why we measure, in addition to aldosterone and cortisol, metanephrine. And moreover, when we remove the adenoma, we can see post-operative glucocorticoid insufficiency.
Then can we identify those patients before surgery?
Yes, we can do that. For primary aldosteronism patients with an adrenal adenoma or CT scan who are planning to go for surgery, it's good to go for a dexamethasone suppression test. This is a simple test where we give the patient dexamethasone in the night before the test, then measure serum cortisol between 8 a.m. and 9 a.m. on the next morning. If cortisol levels are high, above 1.8, this indicates autonomous cortisol secretion. Again, going for surgery needs a team of good surgeons, radiologists, and endocrinologists to properly diagnose, select, and handle post-operative complications.
Ugh. Honestly, that maze of hormones and their interactions get me dizzy. Can you define in detail the medical treatment for PA? It is the way to go in bilateral disease, familial cases, and poor surgical candidates.
The goal is to provide primary aldosteronism specific therapy, which is simpler and more effective than empirical antihypertensives in controlling blood pressure, in alleviating hypokalemia, and reducing the excessive cardiovascular risks associated with primary aldosteronism. Medical therapy will be lifelong and involves mineralocorticoid receptor antagonists. And we have at least 3 of them. All MRAs are anticipated to have similar efficacy when titrated to equivalent potencies. Spironolactone is preferred because of its low cost and widespread availability. However, it has some dose-dependent side effects like gynecomastia, erectile dysfunction, and menstrual irregularities. We have more specific MRAs with less androgen progesterone side effects. We have eplerenone and finerenone. We can use them if the side effects of spironolactone limit its tolerability. We usually start with a relatively low dose, 12.5 to 25 milligrams of spironolactone, and then we up-titrate, and we can reach maximum doses of 200 or even 400 milligrams of spironolactone daily in some rare situations. And once the blood pressure is controlled, non-MRA medications can be lowered or removed to allow for further MRA dosing. We can confirm the success of therapy by measuring aldosterone and finding it suppressed. A rise of renin with MRA therapy serves as a biomarker indicating a restoration of the normal physiology. We have another class of antihypertensive medications that can be useful sometimes. These are the potassium-sparing diuretics or the epithelial sodium channel inhibitors. We have triamterene and amiloride. MRAs are generally preferred over these agents for primary aldosteronism specific medical therapy. Amiloride appears to be sometimes as effective as spironolactone in reducing the blood pressure in individuals with resistant hypertension. However, they do not directly block aldosterone, therefore their impact on aldosterone-induced target organ damage may differ from MRAs. They may be considered as alternative therapies if spironolactone is not tolerated and other MRAs are unavailable.
That was great. We understood that screening for primary aldosterone is a vital step in transforming hypertension care. By identifying this hidden epidemic, we can offer targeted therapies that not only control blood pressure more effectively, but also significantly reduce the serious long-term cardiovascular and renal complications.
Yes, in your next patient with hypertension, think of screening for primary aldosteronism by measuring renin and aldosterone levels in the blood, especially if you have a hypertensive patient with diabetic, unexplained atrial fibrillation, or resistant hypertension. This could be a game changer for millions of people worldwide.
And that brings us to the end of our deep dive into primary aldosteronism. You've been listening to Cardio Buzz, where we cut through the noise to bring you the medical insights that can truly make a difference. Thank you for joining us. To make sure you never miss a beat, subscribe to Cardio Buzz on Apple Podcasts, Spotify, or wherever you listen. If you found today's episode valuable, a 5-star rating and a review would mean the world to us. It helps other people find the show. For a full transcript and links to the Endocrine Society guidelines we discussed today, please visit our show notes. Join us next time as we continue to explore the latest buzz in cardiology. Stay informed and stay healthy.